Hello guys. So now that we are done with the head, neck and face, now we'll go to the next part, that is thorax. In thorax, we'll be learning about cardiology and pulmonology. So to begin with, we are starting with cardiology. So in cardiology, so what we are going to do is we'll study about the basic anatomy, embryology and all first, and the physiology also. Then we'll go on to the specific pathologies that are related to the cardiology. Okay. So to begin with, embryology. So heart develops like in different forms. Okay, so right atria and the left atria we'll see first. Okay, so right atria develops from the cardinal veins and the sinus venosus. Okay, so right atria develops from cardinal vein and sinus venosus, whereas left atria develops from the pulmonary veins, because pulmonary veins is where it gets its blood from, right? From the pulmonary veins is what the left atria develops from. Okay, then coming to ventricles, it develops from bulbus cordis. The proper ventricles will be the proper heart, right? So it is going to be bulbus cordis, and the primitive ventricles is what the ventricles will develop from. Then coming to valves, it is going to be from the endocardial cushioning. Okay, so valves, all of the valves will be developing from endocardial cushioning. Okay, then the septum. Okay, all the atrioventricular septum, interventricular septum, all these septums will be developing from membrane. Okay, so membranous septum. Okay, so this is the thing. Then all the outflow tracts. Okay, so whether it is pulmonary artery, aortic arch, aorta and all will be developing from the neural crest cells, NCC. You remember, right? So NCC from embryology. So this develops truncus arteriosus, and then after that all the outflow tract will be developed. Okay, so failure to develop this outflow tract is what causes the TGA and TOF. Okay, so we'll discuss about TGA and TOF during like embryological abnormalities. Okay, so congenital heart disorders. Okay, this is the thing. Then please remember there is a left, right and left dynin. You remember, right? In Carter-Jenner syndrome, there is a cilia dysfunction which causes it to be situs invertus. So that is the thing. Okay, so if there is a dynin cilia defect, then it is going to cause dextrocardia, meaning so the heart will be on the right side rather than on the left side. Usually all of us have it on the left side, right? Tilted to the left. Okay, so if it is not there, the defect will lead to dextrocardia. Please remember this extra edge point. Now coming to fetal circulation. So this they have asked, this is a previous year question, that is umbilical cord contains 2 arteries and 1 vein. Okay, so please remember this, 2 arteries and 1 vein. Okay, then umbilical vein. Okay, umbilical vein is the most highest saturation of oxygen, that is 80% of saturation will be there with respect to umbilical vein. Okay, so that is what it carries the blood to the heart, right? Blood to the heart is umbilical vein, so 80% of oxygen saturation will be there. Then there are other important points, that is NSAIDs will close the PDA. Okay, okay, so please remember, in patent ductus arteriosus, we can use NSAIDs to initiate closing of the PDA. Okay, then prostaglandins E1 and A2 keeps the PDA open. Okay, keeps the ductus arteriosus open, meaning in certain of the cases, for example, this is the transposition of great artery. Here we'll have to keep the PDA ductus arteriosus open to reduce the cyanosis. So this is where prostaglandins might be helpful. Okay, so please remember these 2 points. NSAIDs will close it, whereas prostaglandins will be opening the and keep open the ductus arteriosus. Okay, then the coronary supply. With respect to the heart blood supply, posterior descending artery origin is what decides the dominancy of the coronary artery supply. Right side is the most common. Okay, so we will be seeing whether it is the right or the left that is dominant. So most common is right side. Okay, posterior descending artery what decides it. Then coming to coronary sinus, the most deoxygenated blood in our body will be in the coronary sinus. Okay, so most deoxygenated body will be the coronary sinus, which is the venous drainage of the heart. Okay, then coming to physiology. So certain of the laws, they don't remember any of the law. I wanted you guys to know only the important things with that law, that particular law. Don't remember any name and all. Okay, Laplace law tells that so thin vessels are less prone to rupture. Please remember only these things, okay? On the right side, what is there? Remember that. Thin vessels are less prone to rupture is what Laplace law. Then flow is inversely proportional to resistance, okay? So flow is inversely proportional to resistance or radius, okay? R to the power 4, okay? Please remember this. Flow is inversely proportional to R to the power 4. This is very helpful when we are trying to decide what during angiogram. This is very helpful to decide what is the amount of, or what is the percentage of block that is being there, okay? This is how we decide what kind of percentage the block has been there. So that is where, and the resistance the block is providing. So that is how we decide, okay? Then coming to wind casal effect, large vessel converts the pulsatile flow into a continuous smooth flow, okay? So this is the wind casal effect. Whereas Bernoulli's principle, pressure is inversely proportional to velocity, okay? Then the Starling forces, the fluid movements in the capillaries. Starling forces are what decides the fluid movements within the capillaries, okay? Then there is Reynolds number. We have been studying this since our physics, right? Since the 11th and 12th. So turbulence, when the turbulence is increases, there is increase in diameter, okay? So turbulence increases in increased diameter vessels, okay? So that is the thing with the Reynolds number. Then coming to cardiac output is SV by HR, right? Systemic vascular resistance, stroke volume into heart rate, okay? So cardiac output is stroke volume into heart rate, okay? Then coming to MAP, mean arterial pressure. See, for example, we know we have BP, right? BP is 120/80, meaning during systole it is going to be 120 pressure that is maintained in the heart, and during diastole, when the heart is not pumping, it is the 80 that is the pressure that is maintaining in the that is maintained in the blood vessel. But if we take a average of this, it is gonna come, the average will be PP, that is pulse pressure, okay? So pulse pressure is the average that the BP might will be getting. But this is a false thing, right? So pulse pressure is not a proper thing. So pulse pressure, because most the heart will be mostly diastolic than systolic. Systole is just one single moment, right? But most of the time heart will be in the diastole. That is why, to know what is the exact blood pressure, or in most of the time we have developed something known as MAP. This tells us during in a heart cycle, what is the basic average of a blood pressure the body is carrying. So that is why we have developed a formula, DBP plus 1/3 PP, okay? So DBP plus 1/3 PP is what is the formula. So normally it should be maintained at 70 to 110. So normal MAP is 70 to 110. This is what is to be maintained in all the cardiovascular disorders. So this is what our target is, not BP or anything, okay? So in any of the surgeries also, it is the MAP that we are trying to maintain, okay? So on an average in the cardiac cycle, what is the blood pressure is MAP, okay? Mean arterial pressure is what is MAP, okay? 70 to 110 is the normal MAP, okay? Then coming on to pressure volume curves. So this has been examiner's favorite, okay? So please remember this diagram and you will be able to solve the pathologies with respect to that, okay? So this is the volume, okay? So this is the volume side and this is the pressure, okay? So y-axis is pressure, whereas x-axis is volume, okay? So end diastolic volume will be high, right? Diastole meaning, so blood is filling, so end diastolic volume will be high, whereas after the whole cycle, end systolic volume will be there, right? End systolic volume is after systole, whatever the blood is there in the ventricles is end systolic volume. So it is not zero, it is having some, at least some little volume will be there in the ventricle, or not everything gets pushed out, okay? So end diastolic volume will be there. Here after end diastolic volume, the mitral valve closes, that is S1, okay? Mitral valve closes, then the pressure increases, the aortic valves open. So at this point aortic valves open, then the blood pushes. So when the blood is getting pushed, the volume is getting decreased. Okay, then suddenly the aortic valve closes. That is where we get S2, right? First sound was lub, okay, that is mitral valve closed, whereas the second sound was dub, that is S2. Here is where the aortic valve closed. So after aortic valve closes, suddenly the pressure drops, right? The pressure gets dropped from the ventricle. So this is where we have reached end systolic volume. Okay, so this is the cycle, cardiac cycle. Okay, so this difference between end diastolic volume minus end systolic volume is what is the SV, that is the stroke volume. Okay, end diastolic volume minus end systolic volume is what have pushed out from the heart is stroke volume. Okay, one stroke has pushed out how much amount of blood is stroke volume. Okay, this is the thing, this is the entire cardiac cycle. Okay, so now let us see in different pathologies when there is valvular pathology. See, this is basically valve. If the valves are correct, so that is when all this cycle will be normal, right? So if the valvular pathology is there, so that is when all these cardiac cycle abnormalities can occur, right? So let us see one by one. Okay, mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. These are the valves with respect to left ventricle, right? So let us see the issues and how the pressure volume curve will be different in each cases. Okay, this has been examiner's favorite. Please note this down. Okay. So it is easier, it will be easier for you if you know the cycle. Okay, so now MS, there will be mitral valve that will be closed, right? So there will be low end diastolic volume because there is not enough blood that is entering the left ventricle. Okay, so in atria the volume is there, blood is there. Okay, but in ventricle there is no blood, so that is why end diastolic volume will be low. Then again the cycle occurs and stroke volume will also be low because the amount of blood that was already present in the ventricle is already low, and it pushed out too much blood, and there will be lesser amount as compared to the normalcy. Okay, this is called mitral stenosis. Then coming to mitral regurgitation, meaning there is too much blood that is being pushed out to artery during the systole itself, right? There is regurgitation of the blood from the ventricle. So that is why there is too much blood coming during the diastole. Okay, so there is too much blood that is coming from the during the diastole, and there is too much blood that is being pushed out, and the stroke volume end stroke volume also will be low. Okay, so that is MR. Okay, coming to AS, you know that, right? AS, the blood is not be there is difficulty in pushing out the blood from the ventricle itself. There is aortic stenosis, so aorta has stenosis, and there is not too much blood that is being pushed out from the ventricle towards the aorta. So that is why, due to the resistance, there is increased pressure in the ventricle. So ventricle is putting too much pressure, so that is why the pressure has been increased. And end diastolic volume will be more because the blood is not being pushed out, all the blood will be remaining here, and also the extra blood from the atria is coming. So that is why end diastolic volume will be low, and end systolic volume will also be high because will be low, will be high in EDV. And end systolic volume will also be high, right? So there is not enough blood that is being pushed out, so that is why end systolic volume remains in the ventricle itself. So that is why, so end systolic volume is also high, end diastolic volume is also high, and the pressure is also high with respect to atrial stenosis. Coming to atrial regurgitation, all the blood is getting regurgitated back, okay, to the ventricle. So that is why end diastolic volume is increased. Okay, end diastolic volume is increased. Okay, and also the end systolic volume also is getting increased because there is all the blood that has been pulling down. Okay, so that is why end systolic volume also will be increased. Okay, whereas the pressure is normal. So okay, it is not, there is no resistance for it. Okay, there is no resistance, that is why, so the ventricle has normal pressure, so that is why the pressure will be maintained. Okay, so please remember this, it is only atrial stenosis where the pressure will be high. Okay, so please remember this. So we'll finish off the valvular pathologies here itself. So mitral stenosis, when we take an ECG, there will be P mitral on the ECG, meaning in normal ECG P wave will be like this, and QRS and T. Okay, so this will be like this, but here in P mitral, the P wave will be large. Okay, P wave will be very large. Okay, so that is called P mitral. Okay, then the on X-ray there will be straight left border. Okay, so on X-ray, as mitral stenosis is there, so all the blood will be pooling in the left atria itself, so that is what makes it very straight. Okay, so too much blood will be filling and it makes a straight border on the left side. Okay, then the murmur will be mid diastolic. Okay, MS is MD, MS MD, remember MS MD. Okay, MS is MD, meaning mid diastolic murmur. Okay, there is a risk of afibrillation. We had discussed in stroke, right? There is an increased risk of a stroke with respect to atrial fibrillation. So that is why we'll be doing something known as CHADS 2 VASC score. Okay, so this is the score that we'll do and decide the should the anticoagulant be given or not. Okay, so that is why in atrial fibrillation, after we are managing the atrial fibrillation, we have to do the thromboembolism. Okay, so thromboembolism might develop, so that is why anticoagulant should be given. Okay, so to prevent the risk of stroke. Then coming to MR, the murmur will be holosystolic murmur. Okay, so entire systole, the murmur will be there. Then there is a complication of mitral regurgitation. Long-term complication will be mitral valve prolapse. Okay, the entire valve might prolapse because the chordae tendineae that holds the valve might get ruptured. Okay, this might lead to a specific sound called mid-systolic click. Okay, mid-systolic click will be in MVP. Okay. Then coming to atrial stenosis, it is a ejection systole. During the systole is what the murmur is, right? So ejection systolic murmur. Then pulses will be weak because there is not too much amount of volume of blood that is being carried from the aorta, right? So that is why the pulse will be weak. Then I'll come back to pulsus parvus et tardus. Okay, please forget that here. Then coming to symptoms, there will be syncope, angina and dyspnea. Okay, just like a myocardial infarction only, because there is not enough blood that is being pushed out from the heart, right? So that is why we'll get to see syncope, angina and dyspnea. Okay, so this is the clinical feature with respect to AS. Then coming to atrial regurgitation, it is the early diastolic blow. Okay, so during diastole, but in the early stage itself, the murmur will be there. Okay, so this is early diastolic murmur, and different signs of aortic regurgitation is very important. Okay, here we'll get to see the water hammer pulse. Okay, water hammer pulse will be there. Okay, weak pulse was in AS, whereas water hammer pulse, because once the blood reached the aorta, it was supposed to move forward, but here because of the regurgitation, it is coming backward. That is why it looks like a water hammer. Okay, so water hammer pulsations will be there. Then Traub's sign, which is like pistol shot femoral pulse. See, basically everything is happening because of the regurgitation. It is like pulling back the blood again. Okay, so that is why we'll get to see all this Traub's sign. Then Quincke's sign will be pulsating nail bed. Okay, pulsating nail bed will be there. Then Demusset sign will be head bobbing will be there. This is all because of the blood has reached the aorta, but again it is taking it back. Okay, regurgitating back. So that is why all these signs will be there. So please remember all these signs. Okay, Traub's sign, then Quincke's sign, then the Demusset sign. Okay, so all these signs. Okay, so this is all and everything you need to know with respect to pressure volume curves and all the valvular pathologies. Okay, so now we'll go to auscultation. Okay, so before going to auscultation, one of the important point is most common cause of valvular heart disease is rheumatic heart disease. Okay, all the valvular pathologies that we discussed now, so most common cause is rheumatic heart disease. Okay, so now let us go to auscultation. Please remember APTM. Okay, appetite. So appetite, you know that, right? The song, Bruno Mars song. Okay, so appetite. Okay, APT. Okay, then M. Okay, so it is going to be aortic area that the A tells. Then so aortic area meaning all the aortic stenosis murmurs will be heard better in aortic area. Okay, this is on the right second intercostal space. Okay, suppose if this is the chest, so here is the sternum, so it is going to be on the right second intercostal space is A. Okay, so because aorta will be traveling like this, right? So aorta will be like this. Then coming to left side second intercostal space, it is going to be pulmonary artery, because pulmonary artery will be traveling like this, right, to lungs. Okay, pulmonary artery will be traveling like this, so that is why the pulmonary area is in the second intercostal space on the left side. So that is where we'll hear the pulmonary stenosis. Okay, pulmonary valve stenosis, and also here is where the heart is. Okay, so here is where the atrial ASD will be heard. Okay, then atrial septal defect will be heard. Then coming to tricuspid area, it will be in the fourth intercostal space. Okay, so tricuspid area will be in the fourth intercostal space on the left side. Okay, so then coming to mitral area, it will be in the apex, that is fifth intercostal space. Okay, so in tricuspid area where we can hear the tricuspid regurgitation, tricuspid stenosis, mainly VSD. Okay, so VSD can be heard in tricuspid area. Okay, then coming to mitral area, it is the apex, right? So mitral area meaning mitral valve. So this is where we can hear better the MS, MR and mitral valve prolapse. Okay, this is the thing with auscultation. Okay, so there is a point between the tricuspid and pulmonary valve called Earp's point. Okay, so Earp's point is between P and T, where the hypertrophic obstructive cardiomyopathy can be heard better. Okay, so please remember this extra edge point, that is maneuvers. There are certain maneuvers. For example, I am not able to hear a murmur, so these are the maneuvers that we do and to hear the sounds that I am thinking of the pathology. Okay, suppose if I am thinking of a pathology that is MVP and HOCM, so there is standing and Valsalva. Okay, standing, when we tell the patient to stand and then we hear the murmur, no, so this will be better heard. Okay, so this will be better heard. Okay, when there is less preload, meaning when the blood pooling is less in the heart, this is when we can hear the MVP and HOCM sounds better. Okay, this is the thing with the standing and Valsalva, and rest all the other murmurs will be in other maneuvers. Okay, passive leg raise, squatting, hand grip and inspiration. All this basically inspiration is what we do. Okay, so to hear all the murmurs, so if it is better heard in inspiration, the murmurs will be proper. Okay, so that is how you can do the auscultation in the cardiac cases. Okay, this is all with respect to auscultation. So now little physiology, basic physiology of cardiology we'll see. Okay, before going into the specifics of pathology. Okay, so the action potential, I had taught about action potential in physiology, right, where basics of action potential. So there I had taught the action potential of the nerves and muscles. Okay, so now let us see the action potential with respect to the nodes and the ventricles. Okay, so I told you right there only, so nodes and ventricles have a different kind of action potential, so that is why we'll learn here. Okay, so first we'll learn about the nodal action potential. What happens is, why is nodes called the main characteristics of the node is the automaticity, right? So from birth till death, so it is the nodes that maintain our heart rate, right? So how is it happening? Because there is no trigger from anywhere. The brain is not giving any trigger to heart to tell it pump and all. Okay, so it is generating its own current. That is why heart has automaticity. Okay, this is a characteristic of heart. Okay, so where does that current come from? There is something called as funny current channel, which consists of sodium, potassium and calcium. Okay, again and again this cycle will happen. There is something called funny current where always all the time, so from our birth till death, this funny current will be active. Okay, we'll come to the phases later. First let us see the action potential, how it happens. So what happens is, this funny current, when it generates a potential of minus 40 millivolts, so that is when the threshold potential is reached. So when minus 40 volts is reached, that is when the calcium influx happens in the nodes. This is I am telling about the nodes. Okay, so suppose this is the heart, remember, right, there is SA node and AV node. This is where this action potential is happening. The rest of the heart I'll tell you later. Okay, the ventricular action potential I'll tell you. Please bear with me with respect to AV nodes. Okay, atrioventricular and SA node. Okay, so now the calcium influx is happening after the minus 40 millivolts is reached. Okay, this calcium influx causes the depolarization of the SA node or AV node. Okay, then what happens is, calcium efflux will happen. Okay, and then the repolarization will happen. So this is the entire cycle of the action potential that is being generated in SA node and AV node. Okay, this is the action potential. See, the calcium influx phase is called phase 0, and the potassium efflux phase is called as phase 3. Okay, I'll come back to ventricular potential. That is how you will get to know why I am calling this 0 and 3 rather than 1, 2 and 3. Okay, so the funny current potential is known as the phase 4. Okay, this is the phase 4. Okay, so please remember this. You will understand when I teach you the ventricular potential. Okay, one more thing I want you guys to know about it is the factors that are affecting this action potential. See, I told you, right, brain doesn't tell the heart to do what. Okay, but brain has a overriding control. Okay, it can tell the heart to raise or diminish the heart rate. Okay, so that is the thing. How does it do? Through sympathetic and parasympathetic system. We had learnt it, right? Sympathetic will act by the beta 1 receptor in the heart and tell the heart rate to increase. Okay, whereas parasympathetic will tell the heart rate to decrease. Okay, this is how the nodal action potentials will be. Now coming to ventricular action potential. So what happens is, so now that the depolarization has happened in the atrium, so now the next action potential is happening. So how does the nerve actually propagates it is, so after the depolarization, it tells the sodium channel that is present in the ventricular cells of the heart. It tells the what happens is there is sodium channel opening. Okay, so sodium channel opens. So this is phase 0. Okay, phase 0, what happens is there is sodium channel opening. Okay, so now after the sodium channel starts opening, there reaches a phase where the sodium channel suddenly stops and the potassium channel starts to efflux, because inside every cell in the human body, potassium will be inside and sodium will be outside. Okay, so suddenly when the action potential is there, what happens is sodium will go in and suddenly starts increasing the positivity of the cell. So what the cell will do is, suddenly after one certain point, it cannot bear the more weight of the sodium also. That is why it will start sending the potassium out. Okay, so this is what is happening. Okay, so potassium starts to efflux out. Okay, so after the potassium starts going out, what happens is, at a certain phase here in ventricles, the calcium influx also starts to happening. Okay, what, because there is too much potassium going out, suddenly the cell will start losing too much positivity. So that is why, to balance it, calcium influx will start happening along with sodium. Okay, sodium influx was stopped already, but now to balance the amount of potassium that is going out, so calcium influx starts happening. Okay, so and the potassium efflux continues, okay, on its own. So now at one certain point, okay, at one certain point, what happens is, calcium channels closes after it tells that okay, now I can't handle this anymore, so calcium channels also close. Now the potassium channel will efflux too much. Okay, so that is when the repolarization of the cell will happen. Okay, so the depolarization was done, meaning excited, this will generate the systole, then all this thing cascade of reaction happened, and then at certain point there is the calcium channel cannot handle the pressure it is getting, then now it will close itself, and the potassium channel has no hindrance, so that is why it will efflux too much. Okay, so too much potassium will be outside. Okay, so this is the too much potassium starts going inside and sodium starts coming in. So now is where the sodium potassium ATPase comes in. Okay, so now the sodium potassium ATPase, what it does is, it will maintain the RMP, meaning, so basically sodium was supposed to be outside and potassium was what supposed to be inside, right? So this is what the sodium potassium pump will do. Okay, so that's it with respect to how the action potential will be generated and how it will reach the resting membrane potential again to get the for the next cycle. So this is from birth till death, this is what is happening inside our heart. Okay, these are called the phases of ventricular cycle. That is phase 0, where the sodium channel opens. Okay, so this is the phase 0. Then coming to phase 1 is this one, where the sodium channel closed and the potassium channel started opening. Then the phase 2 is where the calcium channel influx happened and the potassium efflux is continued, whereas the calcium channel closed and potassium channel efflux started increasing, is where the phase 3 comes in. Then the phase 4 is the potassium channel efflux domination. Okay, so that is the phase 4. These are the 4 phases. Okay, so that is where here also coming to nodal potential, I told you, right? Phase 0 is the depolarization. Here also phase 0 was the depolarization. Depolarization means phase 0. Okay, repolarization here also was phase 3. Here also is phase 3 where potassium is dominated. Okay, coming to phase 4, I told you, right? So there is domination of the basic resting before the resting membrane potential. What is the dominance is there? That is called phase 4. Here also it is phase 4. Here also it is phase 4. That is all with respect to action potentials. Okay, this is how you learn the action potential. Okay, the reason why I told you this was, when we go to arrhythmias, this is all the phases that we are going to target and stop the heart from going into arrhythmia. Okay, so arrhythmia is a random beating of the heart. So this is meaning there is action potential, something wrong has happened with respect to action potential, right? So that is what our target is, and we'll target these phases and we'll give the drugs. Okay, so that is where action potential is important. Okay, now coming to some of the regulators and receptors that are present with respect to cardiology are ANP and BNP. Okay, atrionatriuretic peptide and brain natriuretic peptide. What it does is, the atrial myocytes will be having ANP and ventricular myocytes will be having BNP. Okay, what it does is, during the damage of heart, these ANP and BNP will be released. What happens is, if there is too much blood in the heart and heart is having a failure, then that is when ANP will be released and EANC channel will be activated, which reduces the sodium reabsorption and reduces the water reabsorption. Okay, so from the kidney. Okay, this is what happens with respect to ANP. Coming to BNP, this is what is used in the diagnosis of heart failure. Okay, this is BNP. Then coming to chemoreceptors, there are chemoreceptors and baroreceptors that helps in maintaining the blood pressure, right? So chemoreceptors will be central and peripheral, which recognizes the pH and PCO2, whereas the peripheral receptors will recognize the PCO2, PO2 and pH. Okay, in central there is no PO2. Please remember, there is no PO2 recognition. Okay, it is the peripheral thing that does it. Okay, coming to baroreceptors, this is what maintains the blood pressure, right? So aortic arch, the signals are carried by the cranial nerve 10. The vagus nerve will carry the afferent, whereas in carotid sinus it is the cranial nerve 9, glossopharyngeal nerve is what carries the afferent. Okay, then in CNS ischemia, if there is a for example, let us take a stroke is happening and ischemia is happening. What happens is, there is increased sympathetic activator. That is why the BP increases in stroke patients. Okay, so because heart rate is increased, what it is trying to do is, brain is telling that I am dying, please send me more blood. So that is when heart will increase its heart rate. So this is what happens in CNS ischemia. Okay, there are reflexes. Please remember these 3 reflexes: Cushing's reflex, brain bridge reflex and Bezos-Gerish reflex. Meaning, so what happens is, when there is intracranial pressure increase, so it reduces the heart rate. Okay, when there is increased intracranial pressure, meaning, so I told you about ischemia. When ischemia is happening, the heart rate raised, but when there is edema inside the brain, so brain is telling there is too much blood in the around the brain, I am not able to control it, please reduce the heart rate so that there is reduced blood pooling inside the cranium. Okay, so that is what brain tells. Okay, so this is called Cushing's reflex. Okay, then coming to brain bridge reflex, when there is increased venous return, in certain cases when there is increased venous return, the heart rate will increase, so that too much blood pooling is not there in the heart. Okay, so if the heart rate is not raised, too much blood starts pooling inside the heart only, right? So that will also be a problem. So that is why heart rate increases and sends all the blood out when the venous return is increased. So this is called brain bridge reflex. And contrary to that, Bezos-Gerish reflex, when there is a reduced ventricular filling, when there is a reduced venous return, so that is when heart will start decreasing the heart rate, so that there is enough amount of time to fill too much the reduced amount of blood that is coming. Okay, so there is already reduced blood. If I start increasing the heart rate, what will the blood, what will the heart even pump, right? So that is why it will slow down its rate and allow the heart to relax and fill the blood. Okay, so this is the basal gyrus reflex. Okay, these are certain reflexes that I want you guys to know. Then coming to the two main things, that is JVP and abnormal pulses we'll be seeing here, because before knowing any pathology we are supposed to know JVP, right? JVP and all these things, I'll tell you about it, why we are supposed to know. Okay, clinical significance and all. So JVP, jugular venous pressure, we used to do keep one scale near the neck, and we used to measure the pressure, right? The normal pressure is 6 to 8 centimeters of H2O. Okay, so this is the normal JVP pressure. Okay, so JVP pressure will be, JVP graph will be like this. Okay, so these are A, C, X, V and Y. Okay, so remember A, C, X, V and Y. So A is the atrial contraction. Basically JVP is telling us about the right side of the heart. Okay, so JVP tells us about the right side of the heart, whereas BP tells us about the left side of the heart. Okay, JVP tells us about the right side of the heart and BP tells us about the left side of the heart. Okay, so this is the thing. So JVP is telling about the right side of the heart basically. So what does that mean? It is telling the pressure that is created inside the right atrium. Okay, so that is what is connected to the jugular vein, right? Jugular vein is connected directly to the atrium. So through the SVC. So that is how we are directly measuring the basically what is the function that is happening in the right atrium. So basically it is telling the right atrial contraction, the right ventricular contraction is the C. Okay, this is the C wave. Then the ventricular emptying wave. Then the early atrial filling is what is being told by V, and early ventricular filling. Okay, so this is the entire cardiac cycle with respect to the right heart. Okay, so that is what. Okay, JVP tells us about the right heart. Okay, BP tells us about the left ventricle. Basically not only the left side of the heart, it is specifically to be, it is going to be left ventricles and the systemic vascular resistance this left ventricle is putting on the body. Okay, then one more extra edge point is PCWP. Okay, PCWP will tell you about the left atria. Okay, left ventricle was BP, whereas PCWP will tell you the left atrial function. Okay, this is the basics. Okay, so now that we learnt about JVP, how the waves and all will be, so let us see the clinical significance of it. If now first thing is A wave, right? Atrial contraction. If there is absent A wave, it means that atrial fibrillation, meaning the A wave tells us about the atrial contraction. Suppose if the atria is not able to contract, there won't be A wave at all, right? So that is what absent A wave means. Okay, atrial fibrillation. Suppose if there is a large A wave, it means that there is pulmonary hypertension or pulmonary stenosis, meaning the heart is not able to push its blood towards the lungs, and there is increased pressure. So that is why the large A wave is there. So there is too much pressure in the atrium. Okay, then the canon A wave is when there is complete heart block. Okay, so the blood is pooling inside the heart, and the heart is not properly able to push anything of this out, because there is been block. Okay, block with respect to electrical block. Okay, so that is where we see canon A wave. Okay, then coming to V wave. Okay, so V wave, I told you, right? Early atrial filling will be there. Okay, when there is a large V wave, it means that there is tricuspid regurgitation. All the blood that was there in the right ventricle is being pushed into the right atrium, right? So that is why there is too much blood that is coming to atria. So the early atrial filling will be more. So that is why V wave will be large. Okay, then coming to Y wave. Okay, so this is basically the early ventricular filling. Okay, when there is cardiac tamponade, so around the heart there is blood or some fluid is there. So this is called cardiac tamponade. So this doesn't allow the ventricle to relax properly. So that is why there is no proper ventricular filling, which leads to blunted Y wave. Okay, so blunted Y wave will be there. Whereas in pericarditis, what happens is the heart is very stiff. Okay, so in cardiomyopathy and pericarditis, heart is very stiff. Okay, so there is a rapid descent, okay, with respect to y wave. Okay, so rapid descent will be there because it is stiff and suddenly it should be filled. Okay, so that is why y wave will be rapid with respect to pericarditis and cardiomyopathy. Okay, so please remember this all things. Okay, Kussmaul sign and all, I'll come back again. So now that we have learnt about JVP, let us learn about abnormal pulses. Okay, pulsus parvus et tardus. What does that mean? Pulsus parvus et tardus means that is weak pulse. Where did we see weak pulse? Where the volume is low, that is atrial stenosis. Okay, then coming to water hammer pulse, I told you, right? So regurgitation, aortic regurgitation. Okay, and in the severe cases of AS also we can see water hammer pulse. Coming to pulsus bigemini, meaning there is two heartbeats. Okay, in digoxin toxicity, meaning, so digoxin is what we give, digoxin is what we give when there is a heart problem, right? So heart is not able to beat properly, and that is when we give digoxin and tell the heart to beat properly. Okay, so suddenly what happens, if there is toxicity, there is too much digoxin, it causes two heartbeats. Okay, at one single action potential itself there will be two heartbeats. That is why the name pulsus bigemini. Okay, bigemini. Okay, then please do not confuse with it pulsus bisferens. Okay, where the heartbeat is only one. There it was two heartbeats was there. Okay, in pulsus bisferens it is only one heartbeat, but there will be two peaks in the pulse. Okay, where does this happen? When there is aortic regurgitation. I told you, right? Regurgitation, it is nothing but it is going and coming back, right? So that is why water hammer pulse and pulsus bisferens will be here. Okay, then coming to dicortic notch, it is going to be in the dilated cardiomyopathy. Please remember this. Then pulsus alternans will be seen with respect to severe left ventricular failure. Okay, so there will be too much difference in the pulses. Okay, there will be irregular pulses alternance means there is irregular pulses, no proper pulse. Okay, this is how just by seeing the pulse itself we can diagnose all these diseases, right? So this is why we check for pulse, not only because for the volume or not only because of the rate. It is all the pulses also we can diagnose just by seeing all the pathologies we can just diagnose by seeing the pulses. Okay, now coming to pulsus paradoxus, this is not related to pulse. Please remember, pulsus paradoxus is a misnomer. It is related to BP, not pulse. Okay, so what happens is normally systolic blood pressure reduces during inspiration by 10 mmHg. Okay, so why this happens is during inspiration there is increased ventricular filling. So what happens is there is increased ventricular filling, meaning there is in right ventricle there is too much blood pooling in, right? So during inspiration what happens is due to the negative pressure there is increased blood pooling in, which pushes the left ventricle. Okay, so which pushes the left ventricle. So that is why there is less blood here in the left ventricle. So what happens is the pressure also decreases. Okay, there is less blood here, so that is why the pressure decreases. That is why normally in all of us this is the thing. Okay, so there is up to 10 mm of Hg difference, reduction in SBP will be there. Okay, but what happens in certain of the cases like cardiac tamponade COPD, asthma and hypovolemic shock is there is increased pushing of this right ventricle to left ventricle, because the cardiac tamponade is already like all the blood the fluid is around the heart, and already there is reduced ventricular filling, and this right ventricle is also pushing, so there is too much reduction in SBP. So that is when there is too much reduction in SBP, that is more than 10 mmHg, this is known as pulsus paradoxus, which will be in cardiac tamponade, COPD and all these cases. Okay, so this is what is pulsus paradoxus means. Okay, so now we'll move on to the specific abnormalities with respect to heart. Okay, so all the pathologies and all will move on. So starting with, we'll be going on with congenital heart diseases. Okay, so the most common congenital heart disease is VSD, the ventricular septal defect. Okay, so now let us see what are the types of congenital heart diseases. It is going to be divided as cyanotic and acyanotic congenital heart diseases. Okay, in cyanotic, most common is TOF. Okay, so tetralogy of Fallot. Okay, so basically why is it cyanotic is because There is right to left shunt, meaning from the right heart, all the blood is going to the left. Okay, so that is why it is cyanotic. Okay, left was supposed to be oxygenated, right? So but all the deoxygenated is pulling into the left side, so that is why the cyanosis will be there. Okay, so whereas in acyanotic, the reason why there is no cyanosis is because all the blood that is from the left side is going to the right. Okay, it doesn't have any problem, so that is why till long term also there won't be any problem with respect to acyanotic heart disease. So this is the cyanotic heart disease that is of major concern. Okay, so let us see one by one. So persistent truncus arteriosus. Okay, so failure to divide the pulmonary trunk and aorta leads to cyanotic heart disease. Then coming to TGA, it is the transposition of great artery, meaning the aorta will become the pulmonary artery, whereas the pulmonary artery will become the aorta, meaning all the blood that is coming to the lungs will be oxygenated, and all the blood that is coming from the heart to be supplied to the body is becoming deoxygenated because of the transposition. So that is what, right? So then now note, so that is what I told you, right? PDA. Okay, PDA helps in reduction of the symptoms, because there will be, if the ductus arteriosus is kept open by using prostaglandins, so what happens is there will be increased pressure in the pulmonary artery, and all this pulmonary artery, that is oxygenated blood, can reach the aorta and at least can somehow reduce the symptoms of cyanosis. So that is why if we keep the PDA open in the case of transposition of great artery, the cyanosis can be reduced at least for a little. Okay, so then coming to TOF, tetralogy of Fallot. So there is four things. Okay, tetralogy, there are four things, that is pulmonary artery stenosis will be there, which leads to right ventricular hypertrophy. Okay, so which also due to the right ventricular hypertrophy, the right ventricle pushes a little to the left, which causes the overriding of aorta. This overriding of aorta is caused because of VSD. Okay, so all these four things are there. Pulmonary stenosis is there, right ventricular hypertrophy is there, overriding of aorta, and VSD. This is called tetralogy of Fallot. Okay, so there is a severe case of tetralogy of Fallot, which happens acutely in all the tetralogy of Fallot patients. That is called TET spells. Okay, meaning, so during crying, fever, and during exercise, what happens is there is increased pooling of the blood, right? Because inspiration, all this will cause inspiration of the blood. So inspiration. So during inspiration, so there is increased pooling of blood towards the right ventricle, which pushes too much blood to the left ventricle, right? All the deoxygenated blood will be pushed to the left side. So that is why the baby will become cyanosed during this TET spells. Okay, that is important with respect to tetralogy of Fallot. Then I told you, right? So some of the positions will increase the murmurs also, but here which is in HOCM and in mitral valve prolapse. But see, in TOF, squatting will helps reducing the cyanosis, meaning, so there will be reduction in systemic vascular, there is increase in systemic vascular resistance when someone is squatting. Okay, what happens when there is systemic vascular resistance? So left ventricle starts to puts too much pressure on the right ventricle. So that is why there will be left to right shunting during this squatting. So this will reduce and improve the symptoms. Okay, so this is very important with respect to TOF. Okay, even in your clinical practice this might be helpful. So when we see a child with TOF, he might be squatting because they tell that it improves their symptoms. Okay, so that is the thing with TOF. Then coming to TAPVR, total anomalous pulmonary venous circulation. So meaning the pulmonary veins will drain into right atria. Okay, what happens is, so pulmonary veins were supposed to be draining into lungs. Pulmonary vein, right? So pulmonary vein, pulmonary vein is supposed to drain into left atria, but here it is draining into right atria, meaning all the oxygenated blood that was coming from the lungs is reaching right atria where there was deoxygenated blood. Okay, so then what is the use? There is no blood at all in left atria. Okay, there is no blood at all in left ventricle. So all the blood that is coming from the body and from the lungs is also pulling into right atria. Okay, so this is TAPVR. And because of the arrangement, it would look like a figure of 8. Okay, so we'll come back to the x-ray. Okay, x-rays of all the things, so I'll explain it to you over there. Okay, so now coming to another one, Epstein's anomaly. Here there is atrialization of the right ventricle, meaning the right ventricle will almost become like a right atrium. Okay, so because of the increase in right atrial size, it becomes atrialization of the right ventricle. Okay, so because the tricuspid displaces into the right ventricle. Okay, this is how the pathogenesis happens. This is mainly seen in lithium exposure during pregnancy. We discussed in psychiatry, right? During in bipolar patients, we will be giving lithium. Lithium is one of the best drug, but still it is a teratogenic. Okay, this is the teratogenicity that will cause. Okay, lithium will cause Epstein's anomaly. Please remember this. Okay. Then coming to chest x-rays, this is the examiner's favorite, and this is what has been the question since all these years. Okay, in transposition of great artery, the heart would look like an egg on a string. Okay, an egg. Okay, so this is how the heart would look like. Okay, on a string. Okay, then coming to TOF, we all know, right? Boot. Okay, so boot shaped heart will be there. And then coming to TAPVR, I told you, right? Figure of 8 or snowman appearance. Okay, so it would look like snowman. Okay, so figure of 8. Then coming to Epstein's anomaly, it would look like a box. Okay, so Epstein's anomaly would look like a box because of the atrialization of the ventricle, the heart would look like a box. Okay, please go and see one image from each of these anomalies. Okay, now coming to acyanotic, I told you, right? It is because of left to right. There won't be any problem until and unless some the other issue with cardiac pathology comes in. The patient wouldn't be knowing at all that he is having a congenital disorder. Even I might be having, or you might be having, we wouldn't know because we haven't got any anything with respect to that. Okay, so that is why left to right shunt won't be causing anything until and unless there is some or other issue. Okay, so VSD is most common heart disease, right? Congenital heart disease. It is associated with infective endocarditis. Okay, in infective endocarditis, see, that is what, right? In infective endocarditis, if we contract with infective endocarditis down the line in our life, so then we might go and during the echo and all, when we get a echo, probably we'll get diagnosed as VSD. So that is what happens. Okay, here the murmur will be wide split S2. Okay, wide split S2 will be there, meaning during the dub sound there will be 2 splits. Okay, and the murmur will be hollow systolic murmur, because during the systole itself is when the blood will start flowing towards the right ventricle, right? So this is the VSD. Okay, then coming to ASD, it is ostium secundum defect. You know that, right? I was telling about the atrioventricle and atrioventricular, all the septums will be forming, where in the atrial septum, it is the septum ostium secundum, septum primum and septum secundum that forms the membrane between the 2 atrias. Okay, if there is a defect in that, there will be septum secundum. Okay, septum secundum is the defect that is most common, which will lead to ASD. Okay, so here the murmur will be fixed wide split. There it was wide split, but it is fixed wide split here. Okay, with respect to ASD. Okay, there it might be variable because the ventricular filling difference might be there, but atrial filling difference won't be there anytime. So that is why it will be fixed wide split S2. Okay, then coming to management, it is going to be only when if there is more than 8 mm of defect. Okay, so we'll do transcatheteral surgical closure is with respect to ASD. Okay, then coming to PDA, we all know, right? Machine like murmur. Wherever we see machine like murmur, it is going to be PDA, patent ductus arteriosus. PDA is helpful in TGA. Okay, please remember that. Then coming to Eisenmenger syndrome, it is when this Eisenmenger syndrome happens is when there is a untreated ASD, VSD and PDA. Okay, when this goes untreated because there is no symptoms. So if we leave as such, what happens is this might lead to right to left shunt. Okay, so there is too much blood pooling that is happening towards the right. All these years from left side, all the blood is going towards the right side. But what happens is suddenly, due to increased pressure from on the right ventricle, there is too much hypertrophy that might have happened. So now suddenly after certain years, the right side the shunting might shift to the left side. So this is known as Eisenmenger syndrome. So that is all you need to know with respect to congenital heart disease. Okay, so then this is an important table. Please go through this table. Okay, some of the cardiac anomalies and its association. I told you, right, lithium will be Epstein's anomaly in that way. So many associations are there. If you want, please go through this. Okay, that's it. Then now coming to specifics of cardiac pathology. So these are the tests and investigations when we do that are related to heart. Okay, so BP, I told you, right, it will tell the left ventricular function and the systemic vascular resistance. The pulse pressure will tell about the volume and volume and the left ventricular function, whereas JVP will tell about the right everything about right heart. Okay, heart function. And then coming to auscultation, basically all the valves and all. So basically, see, all this examination and test will tell about the heart. Okay, entire heart, all the plumbing. I told you, right, neurology we studied about electrical thing. Here in heart we are trying to learn about the plumbing. Okay, plumbing work that went on in our body. Okay, so this is the pump. If the pump mechanism fails, the plumbing, entire water supply, that is blood supply to the body, will differ, right? So we'll have to study about the pump and its valves and all. So that this is where how we cannot open all the time and see, right? So this is how we can diagnose based on the all the tests that our scientists have found out. Okay, so left side, right side, all the electrical function will be through ECG we are finding out. Then there is echo that we see the 2D imaging of the heart directly. Then we'll do specific markers. Okay, after MI we'll do specific markers, right, biochemical markers, whether CKMB is raised, troponin is raised and all. So in that way we can know the function of the heart. Then coming to angiogram, we can know all the coronary vessels, whether how they are working, whether it is blocked or not, is with respect to coronary vessels and all. Then coming to CT angiogram, it is a extended version of angiogram, meaning we'll see the calcifications. Okay, we'll get a 3D diagram of the entire heart blood supply and we can see the calcifications around it. Okay, then there is something called thallium study. Okay, so thallium study where we can also diagnose ischemic tissues. Okay, if we are doing angiogram and they tell us some bypass has to be done, what the cardiologists will do is they'll do the thallium test just before going into CABG to know, instead of opening the heart and knowing how much tissue has damaged, just by doing the thallium study we can know how much amount of tissue has been damaged. Okay, ischemic tissue is there. So this is thallium study. Okay, so this is something you should know. Some of the important ECGs are, so WPW syndrome. Okay, we'll discuss more about it. So WPW syndrome, it is Wolff-Parkinson-White syndrome. It is an arrhythmic issue. It will have delta wave looks like this. Okay, delta waves will be there when you see an ECG. If you get a delta wave, it is WPW syndrome. Whereas Brugada, it is coveted T. Okay, so coveted T meaning it will look something like this. Okay, it will be in the V1 and V3. If we see this coveted T wave, it is going to be a ST wave, then it is going to be Brugada syndrome. Coming to dagger Q wave, the P, then Q wave, if it is a dagger shaped, then it is going to be hypertrophic cardiomyopathy. In tamponade, cardiac tamponade, it is going to be electrical alternance. Okay, different waves will be there with respect to ECG if we are suspecting tamponade. Okay, so these are the basics before we dive into the particulars of heart disorders. Okay, so starting with we'll go for vascular disorders and then we'll study about other disorders. Okay, vascular disorders, we are starting with hypertension. So with respect to hypertension, the normal hypertension we all know, right? Less than 120 and less than 80 will be the normal hypertension. 120 by 80 is going to be the normal hypertension. So there are other terms that we give for various values of hypertension. That is, elevated hypertension means 120 to 129 and less than 80. Stage 1 is 130 to 139 and diastole will be 80 to 89. Stage 2 hypertension will be more than or equal to 40 and more than or equal to 90. Then there is going to be hypertensive urgency. Okay, hypertensive urgency means there is more than 180 bar 120 but there is no organ damage, whereas hypertensive emergency, it is going to be more than 180 bar 120 but with end organ damage will be there. Urgency, there is no end organ damage, whereas in emergency there is end organ damage. Okay, there is something called as resistant hypertension, where even after giving 3 different drugs which also includes an diuretic, even then he is not responding to the antihypertensive. That means that he is resistant hypertensive. Okay, so then there are other classification called primary and secondary hypertension. Primary means there is a particular cause of vascular system is there, whereas there is no particular secondary, meaning there is a underlying disease that is causing the hypertension. Okay, so a cause is there, but here in primary there is no particular cause, it is the vessel that is involved. Okay, so this is primary and secondary hypertension. Okay, so in all these stages, these are the stages. Okay, so this is how, based on the stage only, how we treat the hypertension. Okay, so we'll see the hypertension management now. So basically, normal or elevated is there, so that is what 120 130 in that way. So we are gonna do lifestyle changes. Okay, so this is how we do. Okay, then coming to stage 1 and stage 2, if he is a low risk for cardiovascular disease, then again we are going to tell them lifestyle changes only. Suppose if a patient comes to you for 131 till 140, we are going to tell them for to go into lifestyle change only. We won't give hypertension. Suppose if they have cardiovascular risk, if they have will be doing a thyroid test and all the lipid profile test and all. Suppose if we get to see some lipid profile, there is high cholesterol and there might be a risk of cardiovascular risk disease, so that is when we'll add one antihypertensive. Okay, one antihypertensive will be given. Then coming to stage 2, we are gonna go for 2 drugs. Okay, and tell them to review after 1 month. Okay, so after 1 month we'll call them back. Then coming to hypertensive urgency, will give oral antihypertensive. Okay, in urgency, I told you, right, there is no end organ damage, that is why we'll go for oral antihypertensive. Most probably it will be captopril. Okay, AC inhibitors, that is captopril. Okay, so it should be the hypertension should be reduced gradually in 24 to 48 hours. Sudden reduction of the BP should not be done. Okay, it might lead to some damages. Okay, so it might lead to crisis also, so that is why, so sudden reduction also should not be done. Please remember, in OPDs we generally use hydralazine. Okay, so instead of captopril, we generally use hydralazine in hypertensive urgency. If there is 160 170 and all, some patients come in, so we are gonna go for hydralazine. Okay, hydralazine is what we use in OPDs. Okay, because it need not need any monitoring and all, so that is why we are going for hydralazine. Okay, so then coming to hypertensive emergency, it is an emergency situation, meaning that is there is a end organ damage that is happening, so kidney might have failed or some stroke might have happened in that way. Okay, so that is why we will be admitting the patient into ICU. Then we will be giving IV antihypertensive rather than oral antihypertensive. Okay, so basically the drug of choice would be nicardipine, labetalol and selvedipine. Okay, so this is the chosen based on the drug to that particular disease. Okay, underlying disease. Okay, so this is how we do. Mostly it is labetalol, right? So we have all seen our PGs and our professors use labetalol. So that is 20 mg in 2 minutes is the infusion that we give labetalol. Okay, but all this nicardipine and selvedipine we use in that particular case. See, a stroke patient used to come and we used to give nicardipine, right? So in that way. Okay, so please remember in that way. So after this is also controlled reduction of BP, sudden reduction can't be done, and then we will be treating the underlying cause. Suppose it is the renal artery stenosis that is causing the hypertensive emergency, so we'll go and try to treat that particular cause. And if it is the stroke that is causing the hypertensive emergency, we'll go and treat the stroke, so that the finally the hypertensive emergency can be managed, right? So that is the thing. So these are the drug of choices. Okay, so I told you, right, labetalol, nicardipine and cilbidipine is how we use is based on the that particular underlying disease. Okay, for stroke and intracranial hemorrhage, we use nicardipine. So then for ACS and MI, nitroglycerin is what is used. Dissection, it is going to be esmolol. Okay, so beta blocker can be used, right? Then pulmonary edema, nitroglycerin is used. AKI, nicardipine, cilbidipine is used. Okay, and also phenolodopam. Then coming to eclampsia, it is going to be labetalol or hydralazine that we will use. Okay, then you know that, right? In eclampsia, in a patient with a pregnancy that is having seizures, we cannot use ACEs and ARBs. It is the best drugs are hydralazine and labetalol, right? So this is the antihypertensive that we can use. Then coming to pheochromocytoma, we discussed, right? We'll be using bit alpha blocker. Okay, phentolamine. Okay, best choice of drug, phentolamine. Okay, with respect to the emergencies. Coming to, please remember, BMC with respect to antihypertensive, BMC, Bangalore Medical College, that is bisoprolol, metoprolol and carvedilol. Okay, so these are cardioprotective drugs. Okay, cardioprotective drugs, cardioprotective antihypertensives. Okay, so then we are done with the hypertension. Okay, so this is how we do it. Okay, then coming to other vascular disorders, that is aortic aneurysm. We had discussed this, right, in general surgery. So thoracic aortic aneurysm, abdominal aortic aneurysm. Okay, so mainly the in thoracic it is going to be root of aorta that is involved, and it might do aortic regurgitation. Okay, then coming to abdominal, so the clinical features will be pulsatile mass will be there, pain will be there, and resistant hypotension will be there. Okay, so this is how the patient might present with. Okay, we might be thinking some random gastric or some pancreatitis will be there. Okay, so but it probably it will be a abdominal aneurysm which is waiting to get ruptured. Okay, so it is very serious case. Okay, the patient, it is very fatal. Okay, so this is why it is very important. Okay, so when we take a chest x-ray, the figure of 3 appearance. Okay, if it is a trachea, figure of 3 meaning aneurysm will be there. Okay, figure of 3 is how it looks like. Okay, then management will be, so we discussed in general surgery, right? So until 5.5 centimeter we won't be doing anything, so we'll be doing observation. After it reaches more than or equal to 5.5 centimeter, that is when we'll do the surgical intervention. Okay, then coming to aortic dissection, I told you, right, 2 types of classification, Stanford and DeBakey. So Stanford A and DeBakey 1, 2 are same, whereas B and 3 are same. Here it is aortic arch that is involved. Here it is a descending aortic arch, aorta that is involved. Okay, so here the clinical features will be sudden chest pain radiating to back. Okay, this is also an emergency. Okay, then coming to there will be markedly unequal BP in between, okay, in between the arms. Okay, so if we take the BP, there will be BP difference in the questions also. They will be giving you this only. Okay, so there was a BP difference between the 2 arms or between 2 like upper limb and lower limb. That difference will be there. Okay, with respect to aortic dissection, this is the best pathognomic with respect to aortic dissection. Please remember this, markedly unequal BP. Okay, so then there will be unequal pulses also. How do we manage is based on beta blockers. I told you, right, beta blocker is the drug of choice, that is esmolol. Then vasodilation can be done to reduce the pressure, and then we'll go and do the surgery, that is TAVAR. Okay, so TAVAR is what we do. Okay, then coming to the last vascular pathology, that is subclavian steal syndrome. This is an extra edge. Okay, please know. Okay, subclavian steal syndrome is nothing but what happens is there is a left subclavian stenosis. Okay, before the vertebral artery division. Okay, so subclavian artery is there. Here the vertebral artery is getting divided and it is going and forming the circle of Willis, right? So before that division, if the stenosis happens, what happens is the other side, the right side, for example, this is on the left side. So on the other side, the right vertebral artery will go and will form the what the shunt, okay, so will be forming the shunt and giving the blood supply to the arm, okay. So this is how the shunting happens. But what happens suddenly if there is increased demand by the arm? So suddenly if I'm doing an exercise in that left arm, what happens is there is increased shunting, okay. So all the blood that was supposed to reach the brain is now reaching the left arm because there is increased demand of blood. So what happens, suddenly there is low blood supply to the brain, and suddenly the patient might collapse. He might have syncope, okay. So that is the thing with respect to subclavian steal syndrome, meaning the subclavian artery is stealing all the blood, okay. So signs will be that is 15 mmHg SBP difference will be between arms, okay. So between right and left arm there will be increased BP difference. So that is why there will be a differential diagnosis of aortic dissection also here, okay. So this we have to rule out by doing CT angiogram basically, okay. So associated problems with this is Takayasu arthritis might lead to subclavian steal syndrome, and atherosclerosis also can cause this, okay. And also heart surgeries, mainly the new heart surgeries, that is Lima, that is the mammary artery, internal mammary artery that we are using, right? So the new heart surgeries that they are doing, so might lead to subclavian steal syndrome, okay. So this is all and everything you need to know with respect to the vascular disorders of the heart. So now let us move on to ischemic heart diseases and then the arrhythmias, okay. So ischemic heart diseases, there are two things that you have to know, okay. All the heart all the myocardial issues are not ischemia or infarct, okay. So it is going to be two things. One is ischemia, where there is reduced blood flow, then the other one is infarction, where there is death of the tissue, okay. So in ischemia is most common than MI, okay. Please remember that ischemia, there are three things that you are supposed to know, okay. Suppose a patient is coming to you with a heart with a chest pain. So these are the things that you should keep in mind. One is ischemia and the other one is infarction, okay. So ischemia, the patient will be three types, okay. You can segregate them into three types, okay. So stable ischemia, unstable ischemia, and vasospasm. Meaning in stable ischemia there will be, so for example let us take, this is a coronary artery. So there will be a stable thrombus that is formed, okay. So if there is a stable thrombus and suddenly due to some exertion the patient might have the chest pain, so that is where the stable ischemia comes in. There will be no changes in the ECG, okay. ECG there will be no changes at all, okay. Then coming to unstable angina, here the thrombus might have dislodged to somewhere, okay. So that is when unstable angina might have happened, okay. So then there is also called as spasm, where there is no atherosclerosis or anything. Just because of chronic hypertension, suddenly there might be a spasm of that particular artery or that particular coronary vessel, and have led to ischemia, sudden loss of blood flow. So these are the things with respect to ischemia, okay. Please note that in stable ischemia there is no ECG change, whereas in unstable and vasospasm there will be ST depression, okay. ST depression will be there with respect to ECG, okay. This is very similar to NSTEMI. That is why we might confuse the patient with NSTEMI, okay. So we'll see what is NSTEMI, okay. And I'll come back to the cardiac markers again, okay. So here in infarction, this was ischemia, that is reduced blood flow. In infarction there is death of the tissue, okay. Tissue death is there is no tissue death, okay. In infarction there are two kinds. One is subendocardium damage, subendocardium tissue damage, whereas the other one is transmural, meaning all the three layers of the heart is damaged, okay. Here it is only the subendocardium that is being damaged, okay. If only the subendocardium is damaged, then it is going to be NSTEMI on ECG, okay. NSTEMI, non-ST elevated myocardial infarction. Whereas if we see STEMI, that is ST elevated myocardial infarction, it is definitely all the three layers of the heart is involved, okay. So this is very dangerous. STEMI is very dangerous, okay. So please remember, with respect to cardiac markers, this is how we can differentiate between ischemic heart disease and infarction, okay. So there is no cardiac marker changes with respect to ischemia. Okay, so a patient comes to you with chest pain, I'll be doing all the ECG and all. So stable, it is safe because there is no ECG changes and there is no cardiac marker also. Okay, so stable, we'll keep it aside. But there is unstable and vasospasm where there is NSTEMI, that is ST depression is there. So NSTEMI, so now we'll have to differentiate whether it is the infarction or ischemia. So that is when we'll send for cardiac markers, right? So now the cardiac markers comes out and the cardiac markers will be normal. So that is when we'll tell that it is the ischemia that is causing the chest pain. So now if there is abnormal cardiac markers, then it is going to be definitely infarction that is there. Okay, so based on ECG, I have already decided whether it is subendocardium or transmural that is happening. Okay, so this is the basic classification, or this is what you do in your clinics also. So ECG first and then the cardiac markers, both of this will be sending and decide whether it is ischemia or infarction that is happening. Okay, so now let us go on to the specifics of heart disease, the ischemic heart disease. So that is, please note that there is an unexplained, if there is unexplained death that happens within 1 hour of the symptoms appearing, then it is known as sudden cardiac death. Okay, so if all these things are there, the patient died before even reaching the hospital within 1 hour, so it is going to be sudden cardiac death. Okay, so let us see how all the ischemic heart diseases will be managed. Okay, within 10 minutes of patient arriving, we'll be taking ECG. Okay, so ECG is the first thing. Someone tells chest pain is there, we'll definitely, we know that, right? We used to do it in our hospital. The first thing we do it is within 10 minutes we'll be doing the ECG. Okay, then after ECG, so we'll be diagnosing the ECG based on whether MI is there or not, and all the we know that the waves, right? So one of the main thing is important points is pathological Q wave. You know that, right? P wave is there, then Q wave is there, then Q, R, S and T is there. Okay, so suppose if there is a P wave and then there is dagger Q wave, okay, pathological Q wave. Okay, so that is when we can think that it is an old infarct that caused the ischemia or infarction. Okay, so it is if there is a Q wave, pathological Q wave, then we'll think that the patient might be having the old infarct. Okay, so now let us see the specifics of ECG, and based on the ECG itself we can know where exactly the infection or ischemia is happening. Okay, so if it is the V1 and first we are gonna see is the chest. There are 12 leads, right? So chest leads and the limb leads. Okay, so now I'm taking a look at the chest lead, meaning I've put the camera in the 6 different angles in the front of the heart. Okay, then the limb leads are from above and below. I'm taking the camera. Okay, so I'm putting a camera and taking the look basically where the damage in the heart is. So now I put the camera in front of my heart. This is the anteroseptal. Okay, so if anteroseptal meaning V1 and V2, right? So V1 and V2, I'll be placing those leads in front of the sternum, right? So this tells me the left anterior descending artery is the issue. Okay, so left anterior descending artery meaning the anteroseptal V1 and V2. Then coming to apical region, so there is going to be V3, V4. Okay, V3, V4 will tell me. So this is the distal LAD. So distal LAD is affected. Okay, and I'll come back to valence. Okay, so now, so anterolateral meaning V5, V6. Okay, so that is how we place the chest leads, right? V1, V2, V3, V4, V5, V6. Okay, so this is the heart that is there, and it is telling me all the directions. V1 and V2 told me the anterior septal, then V3 and V4 is telling me the apex, then V5 and V6 is telling me the lateral side of the heart. So that is the main thing. Okay, so what is the artery that is supplying? We all know, right? So LAD was supplying this the anterior part, so the left circumflex is supplying the lateral part of the heart. So that is how I can diagnose which artery is being damaged here. Then coming to inferior, so it is going to be 2, 3 and AVF. Okay, so 2, 3 and AVF, the limb bleed. So it's what I'm seeing. Okay, so now I want to take a look at the bottom of the heart. So that is why I'll be taking the look at 2, 3 and AVF. Okay, 2, 3 and AVF. So here if there is STEMI or NSTEMI, I can know that it is the inferior wall that is being affected. Okay, now the lateral side, the left circumflex artery along with the V5 and V6. It is gonna be lateral heart that I'm gonna see. Okay, so LCX again. Then coming to posterior side, it is gonna be V7 and V9. If so suppose a patient comes to you with chest pain, all the ECG is also normal, but he's having classical chest pain, okay, classical myocardial infarction chest pain, but we are still suspecting and we are still waiting for the cardiac markers. So how do you diagnose is based on we can shift the leads and test the posterior side also by placing the leads, that is V7 and V9. Okay, so this is the thing how you can diagnose the posterior descending artery. Okay, so that is the thing with respect to how we can diagnose ECGs and tell whether which artery is inward. Okay, now coming to the cardiac markers, I told you, right, ECG we have sent, which ECG we are already seeing. Now I have sent for cardiac markers. Now the cardiac marker values will come. So now that I can decide whether it is ischemia or infarction. So till 2 to 4 hours it is the tropi that will be raised. Okay, so 2 to 4 hours tropi, within 2 to 4 hours after the ischemic or infarction injury. So within 2 to 4 hours the tropi will be raised. Then coming to CKMB, it will raise by 6 to 12 hours. Okay, by 6 to 12 hours CKMB will be raised. So that is why if someone comes to someone comes to the clinic with heart or chest pain, if I send the cardiac marker and if they have arrived within 2 hours, if I send the cardiac markers, it will be normal only. So that is why we have to wait for a little while and then send the cardiac markers, because we might be there might be false negative might happen with respect to cardiac markers. So that is why we have to go through this. And see, there are recent advancements with respect to tropi and CKMB, where there is early diagnosis also can be done. Okay, so this is the thing with respect to cardiac markers. Okay, so then how do we manage these patients is, so for stable patients it is going to be if it is a stable if it is a stable ischemia that is happening, it is going to be lifestyle changes and aspirin and statins can be given. Okay, so I told you, right, stable angina, here there is no change also, there is no cardiac marker changes also. So now once once the patient comes to me and talks, the prescription that I'm going to give him is lifestyle changes, aspirin and statin will be given. Okay, so then I'll ask him to do a CT angiogram. Okay, basically we'll tell CT angiogram will be made to rule out any further damage. Okay, so we'll rule out the CT angiogram and then we'll give the lifestyle changes, aspirin and statin, based on the amount of damage that has happened in the coronary arteries. Okay, so then the drug of choice to maintain that will be beta blockers and calcium channel blockers. With respect to vasospasm also, calcium channel blockers will be given. Okay, and we'll also tell him to keep GTN, that is glyceryl trinitrate, if there is an acute attack. Okay, so if there is an acute attack, so to be safe, we'll tell him to keep a glyceryl trinitrate in home. If needed, he can take it. Okay, so this is the thing with respect to stable angina. Now coming to unstable angina and NSTEMI. Okay, so now it is same for unstable angina and NSTEMI because unstable angina can complicate into NSTEMI, right? Unstable angina is itself NSTEMI, but it can complicate to infarction, right? So that is why the protocol is same with respect to ACS. Okay, so ACS protocol is same, that is aspirin will be giving, clopidogrel and anticoagulant. Okay, then statins and the nitrates will be giving. Okay, so this is the ACS protocol that we follow. Okay, so then if needed, SOS, morphine and O2 will be giving. Okay, so we'll admit the patient. This is the ACS protocol we will be following with respect to when there is a STEMI. See, NSTEMI meaning there is ECG changes, so that is why we are admitting him. Okay, ACS protocol is formed where we'll be giving ACS, basically aspirin, clopidogrel, statin. Okay, then the extra ones are anticoagulants and nitrates. Then if needed, if the pain is very severe, we are going to go for morphine, and if needed, oxygen supply will be given. Okay, the oxygen supply, please be careful, please do not give for everyone, only if needed is given, because it might cause reperfusion injury also. Okay, so reperfusion injury by ourselves we will be causing the damage. Okay, so that is why Oxygen perfusion should be not given for everyone, only when there is SpO2 lowering. So that is when we'll go for oxygen delivery. Okay. Then coming to, this is with respect to unstable angina and NSTEMI. So coming to STEMI, please remember 90 plus 30 is equal to 120. Okay, so please remember this formula. What does that actually mean? Meaning, if there is a cath lab in my hospital, if there is a cath lab that is present in my hospital, what we are going to do is, we'll do PCI in 90 minutes. Within 90 minutes we'll do. Okay, if I have a cath lab in my hospital. Or else if the cath lab is not available in my hospital, okay, the patient has come to your hospital, there is no cath lab, what we are going to do is, we'll push the patient outside. Okay, within 30 minutes, door in door out will be 30 minutes. Within 30 minutes we'll push the we'll give all this all the other drugs, that is aspirin, clopidogrel, all this thing we'll load the patient, and then we'll send the patient to a place where the cath lab is there. Okay, within 30 minutes it should be out, and the PCI should be done within 90 minutes. Okay, so there, once after reaching, he should be getting the PCI within 90 minutes. Okay, so that is totally 120 minutes, right? So please remember 30 plus 90 is equal to 120. Okay, if you remember this, it will be very easy. Okay, then for triple vessel diseases, we are going to go for CABG. So in cath lab, what we are going to do, in cath lab we'll be doing the angiogram and we'll be stenting them. Okay, so stenting will be placed for temporary management, whereas in triple vessel diseases we might have to go for CABG, right? So the bypass graft. Okay, so please remember the newest like not new. Okay, so this has been there, but more than in the older days they used to take the graft from the legs and all, so from the saphenous vein, but now it has been improved to the internal mammary arteries, IMA. Okay, so internal mammary arteries, the BIMA procedure, that is bilateral internal mammary artery, has been used as best way, right? So best way to just graft from there itself, right? So you need not remove from anywhere. So in TVD, BIMA is also used, and also the grafts from the leg, that is with saphenous vein, is also being used. Okay, so this is the entire management with respect to the ischemic heart disease. You got to know, right? Once a patient comes to clinic to you, this is all and everything that you do with respect to ischemic heart disease. So now moving on further with the arrhythmias. Okay, so now heart disease, ischemic heart disease is done. Now we'll move on to arrhythmia. So meaning, so arrhythmia is irregular heart rate. Okay, so it can be either tachycardia, meaning more than 100, or bradycardia, which is less than 100 beats per minute. Okay, arrhythmia meaning there is irregular heart rate. It might be higher or it might be lower. So our concern is higher, that is tachyarrhythmia. Okay, so tachyarrhythmia has different types of classification that can be done. So one is based on the mechanism. Okay, so classification based on mechanism is where there is increased automaticity, where there is increased trigger that is happening, or if there is an issue with a re-entry circuit. Okay, so this is of not much of importance. The major importance is based on origin and based on the QRS complex. Okay, we'll see what is it. If the origin is above the bundle of His, the arrhythmia is happening above the bundle of His, you know that, right? The bundle of His is there, which is supplying the Purkinje fibers, and all the ventricles will be there. Here the SA node is there, AV node is there. So this is the bundle of His. Okay, if it is the above the bundle of His, the issue is there, then it is going to be supraventricular tachycardia. Okay, supraventricular tachycardia and supraventricular tachycardia with the bundle block. Okay, so these are the two kinds of things with respect to above the bundle of His. Then below the bundle of His, meaning below the bundle, meaning Purkinje fibers and all this is affected. So that is where the ventricular arrhythmias come in. Okay, so this is the major difference with respect to origin. Then coming to based on QRS complex, so it is going to be narrow QRS, slightly wide QRS, and wide QRS. So this is the classification of based on QRS, the arrhythmias. Okay, so now let us look one by one. Okay, so the supraventricular tachycardia is what is very important. Okay, so above the bundle of His is what is our focus. Okay, ventricular tachycardia I'll teach you, but now the focus will be above the bundle of His. What is the issue? Okay, so it is called paroxysmal supraventricular tachycardia. Paroxysmal meaning it is not always present, but it comes and goes. Okay, so in that way, that is the meaning of paroxysmal. Okay, so paroxysmal meaning comes and goes. Okay, so this is the meaning of it. Okay, so this is PSVT. Coming to it is a narrow QRS. I told you, right, based on QRS also we'll be dividing them. So PSVT will be narrow QRS arrhythmia. Okay, so there are three kinds of PSVT, that is AVNRT, AVRT and atrial tachycardia. What are those? So basically AV nodal reentrant tachycardia, meaning there is an issue in the reentrant circuit. Okay, so this is a big chapter. Okay, so AV node, just I'll tell you a simple thing. So there is a reentrant circuit is there. Okay, so which basically maintains the electrical rhythm in the from atria to ventricle. So if that reentrant circuit is affected, then the AVNRT will happen. Okay, so there are two types, that is typical and atypical type. Okay, so here the ECGs are important with respect to this. ECG will show 200 to 250 beats per minute. Okay, with respect to AVNRT, it is going to be 200 to 250 beats per minute, and AVNRT will be regular. Okay, so the waves will look regular, and P wave won't be there. Okay, so when we see an ECG, the P wave won't be there. All the only the QRS will be there, meaning the P wave is buried inside the QRS complex. Okay, so that is the meaning with respect to AVNRT. Okay, then coming to AVRT, it is the bundle of Kent. Okay, so here I told, right, reentrant circuit is affected, whereas in AVRT there is something called bundle of Kent. Okay, so this is a cardiac anomaly, in only certain people it will be there. So there is something called bundle of Kent which supplies the atrial muscles. Okay, so this bundle of Kent, only in certain people it will be there. If that is there, it is a problem actually. So that is where the WPW syndrome, I told you, right, Wolff Parkinson White syndrome might occur. Okay, delta wave, I told you, right, the ECG might look like delta wave. So here is where AVRT, the AFib, atrial fibrillation, might occur. Okay, so these people have highest risk of atrial fibrillation. Okay, there are two types, orthodromic and antidromic. Okay, then coming to ECG, it is more than 150. There it was 200 to 250, right? Here it is going to be 150, more than 150 beats per minute. And afibrillation, right, I told you, right, afibrillation, fibrillating. Okay, so irregular waves. Okay, regularly irregular waves. Okay, then P wave is after the QRS. Okay, so in AVRT the P wave might come after the QRS complex. Delta wave is there. After the delta wave, the QRS complex will be there. So this is how the ECG might look like with respect to AVRT. Coming to atrial tachycardia, it is because of the structural abnormalities that might have happened. I told you, right, atrial tachycardia might happen in mitral stenosis and all these things. So there will be structural abnormality, so which will lead to atrial tachycardia. Okay, so here also it will be 150 beats per minute. Okay, P wave will be before QRS, just like normal thing only, but the PR interval will be shortened. Okay, so PR interval will be shortened, so that is where the tachycardia is occurring. Okay, so then the other arrhythmias that are important are axis deviation, the bundle block, and the hypertrophy. So in axis deviation, how do you differentiate between left axis and right axis is, see the first and AVF. Okay, 1 and AVF. Okay, 1 and AVF ECG leads we are gonna see, and if we are suspecting the deviation in a patient, the axis deviation, then if it is a left axis deviation, it is gonna leave each other. Left meaning leave. Okay, L for L. Okay, whereas right axis it is gonna reach for each other. Okay, so the wave, okay, if it is a left one will be one lead one will be like this, and AVF will be like this. Okay, if it is gonna be left axis, whereas in right axis it is gonna be one will be like this, and AVF will be like this. Okay, so it is reaching each other, right? So this is going to be right axis deviation. So this is how you can differentiate between the left axis deviations. Then coming to bundle branch blocks, you know that, right? William and Marrow. Okay, so left bundle branch block, it is going to be V1 will look like W, whereas V6 will look like a M. Okay, So V1, if I take a look at V1, it is going to look like W. Okay, so W will be there. Okay, when I take a look at V6, it is going to look like M. Okay, so M will be there. So this is how the ECG would look like. Okay, so right bundle branch block would look the opposite way. V1 would look M and V6 will be W. Okay, so this is the difference with respect to bundle branch blocks. Okay, coming to hypertrophy. It is going to be left. If it is left ventricular hypertrophy, V1, okay, V1 there will be increased more than seven boxes. Okay, V1 the S wave will be increased more than 7 boxes, and V6 the R wave will be increased more than 7 boxes. Here in RVH, the right ventricular hypertrophy, V1 will increase more than 7 boxes, right? So because heart is increasing on the right side rather than it was supposed to be like this. Okay, so if it is hypertrophied on the right side, V1, right, V1 is what we are measuring. Too much R wave is coming. Okay, so that is why the R wave will be increased. Okay, so this is hypertrophy. Whereas in left hypertrophy, see, here we are giving V5 and V6, right? V6 meaning it is deviating too much to the left side, and that is why we are getting the increased R wave. Okay, that's it with respect to right hypertrophy. So these are the certain arrhythmias that you should be aware of. Now coming to management of arrhythmia is what is very important. Okay, so PSVT, the management of PSVT is what is very important with respect to all the previous year questions. Okay, so what happens is, first when the patient comes to you with all these palpitations and all, so first thing we'll do is we'll check for all the vitals, right? So if the vitals are stable, there is a different protocol, and if the vitals are unstable, it is a different protocol that we'll follow. Okay, if the patients are stable, what we'll do is we'll do something called as vasovagal reflex or maneuver. Okay, so what we do is we try to tell him to there's a vasovagal reflex. We'll tell him to blow into a empty syringe, and suddenly if you see the heart rate on the monitor, so suddenly it starts decreasing. Okay, we'll tell him to take a deep breath and tell him to blow. This is the vasovagal reflex. Okay, you yourself do it and check it. It works actually. Okay, so vasovagal reflex. Then if the vasovagal reflex is not working, then we are going for adenosine. Okay, so adenosine is the drug of choice. Then after that, calcium channel blockers and beta blockers. I'll come back to you how we chose this adenosine and calcium and beta blockers. Okay, so now if the patient is unstable, that is when we will do the cardioversion. Okay, so synchronized cardioversion is done, and if there is no change of even after doing the cardioversion, that is when we'll go for catheter ablation. Okay, here also if it is not working, we are going to go for catheter ablation. Here also if it is not working, here we are going to go for catheter ablation. So this is the basic management of PSVT. Okay, this is how we do. Okay, this is very important. This is what the previous year questions have been through. Then coming to the antiarrhythmic drugs, I told you, right, how did I choose adenosine, calcium channel blocker? So this is how we choose. Okay, so remember ABCD. In antihypertensives also it is ABCD, right? ACE inhibitors, ARBs, beta blockers, calcium channel blockers, then the diuretics. Here also it is ABCD. Okay, so first is adenosine, then the beta blocker, then we'll go for calcium channel blocker, then we'll go for digoxin. Okay, this is how we choose the antiarrhythmic drugs. Okay, so please remember, in atrial fibrillation, the drug of choice is diltiazem. Okay, so if we are seeing atrial fibrillation, it is going to be diltiazem that we are dealing with. Okay, so how does the atrial fibrillation look like? It is going to be fibrillating. Okay, so fibrillating will be there. Okay, QRS will be normal, but the P wave and all these things will be fibrillating, whereas flutter will be like fluttering, sawtooth. Okay, it looks like a sawtooth. How does the saw basically a machine saw work? Like right, flutter. So it is how you can remember flutter will look like this. Okay, so this is how to differentiate between fibrillation and this one. Okay, flutter. So now I've told you that ABCD drugs is how you choose. Okay, please remember, in WPW syndrome, I told you, right? So WPW syndrome, bundle of Kent, we will avoid all these ABCD drugs. Okay, instead of that, we'll be going for amiodarone. Why? Because see, there is an extra nodal circuit that is bundle of Kent, and if I use this ABCD drug, So suddenly it will cause to stop all this normalcy, and here the bundle of Kent will start increasing its action again. Okay, so bundle of Kent itself was the problem. I gave ABCD, and suddenly that bundle of Kent will gain more power, right? So because the normal working circuit is being affected, so that is why we'll try to avoid ABCD, and we'll give amiodarone. Okay, amiodarone works in WPW syndrome. Okay, so this is the thing. Now coming to all the PSVT is done. So now coming to ventricular tachycardia. Here the management is ventricular tachycardia. When will we get ventricular tachycardia? Basically when the heart is not functioning and when we are doing CPR, right? So when doing CPR is when we go check when the ventricular tachycardia mostly be there. So we'll check whether the person is with pulse or without pulse. Okay, if without pulse, then we are going for ACLS protocol. You know that, right? CPR and all the drugs that we use during CPR, that is adrenaline, all these things. Okay, so we are going for ACLS protocol, and we'll do the defibrillation, right? So this is where the defibrillation comes in, with if there is without pulse ventricular tachycardia. Okay, then if there is pulse, okay, so suppose if we start getting the pulse here, then we'll turn on to this process. Okay, suppose now the pulse have regained, or the person has already been having the pulse. Okay, so then we'll check for the patient vitals. So if the patient is unstable, we are going to go for DC cardioversion. Same like in PSVT, here also cardioversion if it is unstable patient. If it is a stable patient, we are going to go for amiodarone. Okay, amiodarone 150 mg per IV. This is the best drug for ventricular fibrillation that we can give. Okay, so ventricular tachycardia, amiodarone. Please choose amiodarone. Then after that we can go for proconamide. Okay, so proconamide is also one of the best drug for ventricular tachycardia. These are the things that should be in your mind. Then the mechanism of action of antiarrhythmic drugs. So class 1, class 2, class 3, class 4. This was the previous year question. It was asked in 2025. Okay, so please remember this. Where exactly do this act? So I told, right, all the action potential waves in the phases are there. So there we can go and attack and put these drugs and attack that particular phase of action potential, ventricular action potential. So this is the thing. Okay, so class 1 and 3. Okay, so class 1 and 3 will act on the ventricles. Okay, so ventricular action potential, whereas class 2 and 4 will act on the nodal potential. Okay, please remember this. Okay, so based on what particularly is happening, I'm gonna choose that particular drug. Okay, so class 1 and 3, I told you, right, ventricular potential is affected. So class 1 is sodium channel that is being affected, whereas class 2 is beta blockers. Okay, then coming to class 3, we are going to go for potassium channels, and class 4 is calcium channels. Okay, so this is how you can remember. So the examples of the class 1 is lidocaine, all this quidine. Okay, so these are the drugs. Then coming to beta blockers, you know, right, propanolol, all these things, atenolol. Then coming to class 3, it is going to be amiodarone. We know that, right? Ventricular tachycardia, we gave amiodarone, and also in WPW syndrome we gave amiodarone. Okay, then coming to class 4, it is going to be calcium channel blockers, that is verapamil and diltiazem. Diltiazem is the drug of choice in respect to AFib, I told you, right? So this is the thing. Then coming to adenosine, okay, it basically acts on the phase 0. Okay, phase 0, this is considered as class 5 drug. Okay, so class 5 is amiodarone. Okay, sorry, adenosine. So adenosine acts on the phase 0. You know phase 0, right? So all the depolarization phases is known as phase 0. So this is where the action potential is there. Then coming to half life, it is going to be only 10 seconds. So that is why when we are giving adenosine, it is very important to push it very quickly. So within few seconds it will reduce its half life. I mean it will degrade. So that is why it is very important to give it very quickly and give it directly. Okay, you will give directly to the towards the vein. Okay, so that is how it will act. So the dosage will be 6 mg IV. Okay, so with 20 ml NS is the dosage that we give. Okay, so at 6 mg IV push is what we are going to do. Okay, with 20 ml NS. Okay, so this is the thing with respect to antiarrhythmics. Okay, some of the I told you, right, atrial fibrillation, there is a risk of stroke. That is why Chadsby score. Will come back to that. I've explained it in neurology chapter. Okay. Then coming to conduction blocks, there are three types of conduction blocks. There is that is type 1, type 2 and type 3. In type 2 there are two types, that is Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also called as Wenbach's. Okay. So in type 1 there is PP interval, okay, prolonged PP interval, okay, between the P there is prolonged interval is there, so that is known as, it almost looks like a bradycardia, but P, between P and P, not between R and R. If between R and R the difference is there, that is bradycardia, but if it is between P and P, that is what I am looking, it is gonna be conduction block, that is first degree conduction block. Then as it moves on, as it progresses, there is progressive PR lengthening, then it is going to be, then a final one beat drop will be there, so then it is going to be Mobitz type 1. When if there is a sudden beat drop, if there is no progressive lengthening and suddenly there is beat dropping, then it is going to be Mobitz type 2. Okay. Then coming to type 3, it is dissociated. Okay. So there is no association between P and QRS waves. Okay. So that's it. Okay. How do we manage this? So type 1, it looks like a bradycardia, nothing will do. Then coming to type 2, we are going to give atropine and increase the heart rate. So this is how we try to match the heart rate, and we'll block the second degree heart block. Then coming to the third degree heart block, it is going to be the pacemakers. Okay. It needs a long-term treatment, that is why pacemakers, artificial pacemakers will be introduced here. Then coming to the last few topics of the cardiology, it is going to be cardiomyopathy. Please remember, there is two types of cardiomyopathy, that is dilated and hypertrophic. Okay. In dilated, it is going to be Takotsubo cardiomyopathy, which is also called as broken heart syndrome. Okay. So this happens because of stress. Okay. Takotsubo meaning it looks like a octopus bowl. Okay. So in Japan they use octopus pot. So this is what the heart ventricle would look like, left ventricle would look like octopus pot. So that is why the name Takotsubo. Okay. Then coming to peripartum dilated heart disease, meaning in post peripartum some stress might be there and dilation might be happening. So this is the peripartum dilation of heart. So here is where we will use bromocriptine. Where else did we use bromocriptine? In remember dopamine with respect to prolactinoma and all. So that is where we used bromocriptine, right? So here also we are going to use bromocriptine. Then coming to hypertrophic cardiomyopathy, there is obstructive HOCM, that is right, HOCM, hypertrophic obstructive cardiomyopathy. Okay. So then the apical echo would look like a ace of spade. Okay. So like just like ace of spade, it is gonna look like. Okay. So this is how the ace of spade is. So this is what the echo would look like. Okay. Then coming to management, it is basically we are treating the underlying cause. Okay. So underlying cause is what we are supposed to treat. Okay. Than treating cardiomyopathy. We can't treat cardiomyopathy. Remember SGLT2. Okay. SGLT2 inhibitor that we use in diabetes and all has been proven good for treating hypertrophic cardiomyopathies and all. Okay. So please remember this drug SGLT2 inhibitor. Okay. So has been proven, has been like not reversible, but has been proven to be causing improvement with respect to remodeling and all. Okay. So this is one drug. Then coming to cardiac tamponade, I told you, right, there is fluid around the heart in the pericardial membrane, around the pericardial membrane. So if it is more than 100 ml, we are going to call as cardiac tamponade. Okay. So it is a medical emergency. So that is why it might lead to cardiac arrest also. Okay. So because there is improper beating of the heart. Okay. So there is Beck's triad. This is the classical clinical feature of cardiac tamponade, where there is hypotension, blunted JVP that I discussed, right? So blunted JVP meaning there is distended jugular venous vein. Okay. So then there is muffled heart sounds that are heard. Okay. So muffled heart sounds might be there. Then coming to other clinical features that the patient might come up with is chest pain and dyspnea. Okay. So then coming to pulsus paradoxus, I discussed, right, more than 10 mmHg of reduction in BP. Okay. So this might be there with respect to cardiac tamponade. And then ECG we already discussed. Electrical alternance will be there. The ECG waves will be too much difference will be there, like, just like a fibrillation or flutter. Okay, how do we manage them? Mainly pericardiocentesis. Okay, what do we do is 16 or 20 gauge needle will take and we'll insert it just below the xiphoid process at an angle of 30 to 45 degree. Okay, so then we'll extract the fluid. Okay, so this is known as pericardiocentesis, is what we do for cardiac tamponade. Okay, the last parts, that is infective disorders of the heart. Okay, so infective disorders of the heart, once finally this is done, we are going to go for heart failure. Okay, so finally all and everything we have discussed. So finally if nothing nothing works, so finally the heart will fail, right? So that is why we'll learn about heart failure at the last. Okay, so now we'll go on with the infective disorders of the heart. So in infective disorders, so it is going to be RHD, that is rheumatic heart disease, infective endocarditis, NBTE, and Liebman-Sachs disease. Okay, so we'll discuss one by one with respect to like how the vegetations will be. Okay, so RHD, it is along the valves. Okay, along the valves it will be quite large. Okay, quite small. Okay, so with respect to RHD, whereas infective endocarditis, it is going to be infiltrating the valves. Okay, then coming to NBTE, it is going to be small and single. Okay, compared to RHD, in NBTE it is going to be small and single, whereas in Liebman-Sachs, it is going to be on the both sides of the valve. Okay, so this is very important. This is a previous year question. Okay, so previous year question, so please remember this thing. Then coming to rheumatic heart disease, we'll study about the specifics of rheumatic heart disease and infective endocarditis. Rheumatic heart disease, I told you, right, in microbiology, this is streptococci. Okay, group A streptococci. So please remember group A streptococci. Okay, so features will be mitral valve more than aortic valve involvement. Then histology, it will be Aschkoff body. This is very pathognomic to rheumatic heart disease. Aschkoff bodies will be there. Okay, then coming to pathogenesis, it is the so basically what happens is to fight streptococci, so our antibodies have generated. Okay, but it confuses with the M protein of our myosin. Okay, M protein cross reaction with our myosin. Okay, so will happen. Okay, so that is when the pathogenesis will happen with regards to RHD. This is an autoimmune, right? So autoimmune trigger was the group A streptococcus. So post that all our antibodies is trying to fight our own the myosins. Okay, so there is a criteria called Jones criteria. Okay, please remember it as Jones only. Okay, so Jones. Okay, these are the features that the patient presents with, and this is how we'll diagnose the rheumatic heart disease. So this is the diagnostic criteria. Basically, Jones meaning joint. Okay, migratory polyarthritis, joint. Then O is pancarditis. Then N for nodules, and E for erythema marginatum. Then the syndrome scoria. Okay, so these are the way that the patient presents with, and this is the diagnostic criteria. Okay, coming to the management, it is going to be benzathine penicillin that will give, and it will be 6 lakh international units. Please remember 6 lakh international unit. It is a previous year question. And for prophylaxis, it is going to be benzathine penicillin for 10 years, 3 weekly, or else we are going to go for 25 years if it is 1 weekly. Okay, so 3 weekly meaning 10 years benzathine penicillin can be given. So that is with respect to RHD. Now coming to infective endocarditis, it is going to be Staph aureus more than streptococci. Okay, there it was group A streptococcus, but here it is Staph aureus that is infecting. Or I told you, right, with respect to Coxiella burnetii. Okay, please remember this. I'll tell you again in cardiology. So this is the thing. So Coxiella burnetii, there will be negative culture. Okay, so culture will be negative. Okay, but when we see the echo and all the other criteria will match the infective endocarditis. Okay, so this happens because of a sequel of dental procedure, some dental procedures, some root canal or some treatment. Okay, wisdom tooth extraction. So there might be the transmission of Staph aureus. Okay, it will travel inside and attack the heart. Okay, so the features will be fever will be there, murmurs will be there, then more than one valve might be affected, and endothelial injury is there, so that is why the vegetations and thrombi. Okay, so vegetation and thrombi occurs because of this endothelial injury only. Okay, so the criteria there was Jones criteria, here it is Duke's criteria. Okay, so remember B timer. Okay, B timer is the mnemonic, meaning B for blood culture, okay, E for echo. So this is the major criteria that should be there. Then coming to minor criteria, timer meaning temperature, then immunological phenomenon, for example Janeway lesions, Osler's node and Roth spots in eye, retina. Okay, so these are the things that should be there with respect to minor criteria. M is microbiology, that is positive. Then emboli, it should be there. Then risk of CHD or IV drug use, all this category will fall into minor category. Okay, minor criteria. Then how is the management done? So basically infection, right? So infective, I mean IV antibiotics is given. So if vegetations are there, we'll go and remove the surgical removal of the vegetation is done. So we studied, right? It is going to be this infiltrating the cords also. Okay, so valves of the chordae and all, so that is by the surgical removal. Okay, or else if it is not possible, then we are going to go for valvular replacement. Okay, so please note here also prophylaxis will be penicillin. Okay, before the dental procedure. Okay, in high risk cases only will be giving the penicillin prophylaxis. Okay, then this is all and everything you need to know with respect to infective disorders of the heart. Now the last topic, that is heart failure. Okay, so what is heart failure? Basically it is inability of the heart to pump the blood. Okay, so what does that mean? Normally the ejection fraction, okay, so normally stroke volume by cardiac output is basically the ejection fraction. So it will be 55 to 70. Okay, so 55 to 70 will be the normal ejection fraction. So when there is issue with that particular ejection fraction, meaning there is improper blood, that is improper ability of the heart for to pump the blood. So that is when there is two types of classification that can be done in heart failure, that is right heart failure and the left heart failure. Okay, then there is something called as heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. Okay, so let us see one by one. So heart failure with reduced ejection fraction, so this happens most commonly in myocardial infarction patients. So what happens is there is a weak pump. Okay, so the heart's ability, because the tissue is dead, the heart isn't able to get its all the blood outside through the aortic valve. Okay, so that is why the all the blood stays here in the ventricle only. So that is why the weak pump will be seen in a reduced ejection fraction. Okay, so here the ejection fraction will almost be reduced, less than 40 will be there. Okay, so that is why we'll give ACE, ARNI, beta blockers and SGLT2 inhibitors. Okay, so the reason why we are doing is, at least, yes, if we reduce the systemic vascular resistance by giving antihypertensive, so at least some blood can move out, and at least some blood can move out and perfuse the tissues. So this is our goal with respect to reduced ejection fraction. Okay, so if complete failure is there, then we are going to go for ICD device. Okay, so this is the management that we do for reduced ejection fraction. Whereas preserved ejection fraction, you are telling heart failure, so there might be there should be ejection fraction reduced, right? But no, here what happens is there will be preserved ejection fraction. What does that mean? Meaning, so in aortic stenosis or chronic hypertension, what happens is the filling itself will be reduced. Okay, so suppose this is the left ventricle, there will be too much hypertrophy, right? Hypertrophy will be too much. Okay, so because of too much remodeling that has happened because of the pressure that was created in the left ventricle, so already the blood filling itself is low. So when I take the ejection fraction, okay, ejection fraction meaning, so stroke volume by the end diastolic volume, if the end diastolic volume itself is reduced, so then there will be no change in the ejection fraction, right? So this is what is the meaning of preserved ejection fraction. So basically there is stiff ventricles, okay, and the EDV, that is end diastolic volume, is reduced. So that is why when we see the ejection fraction, it will be more than 50%. But in echo there is the but in echo there will be the hypertrophy will be there, and akinesia, almost the blood supply itself is not there. The patient has a failure like symptoms, syncope and heart chest pain and all these things is there, blood pooling is there, and all these things will be there. So that is when we'll diagnose a preserved ejection fraction heart failure. Okay, so I told you, right, in cardiomyopathy also I told you SGLT2 inhibitors have been helpful in reducing the cardiac remodeling. So this is the research that has been going on. So reducing the cardiac remodeling can be done through SGLT2 inhibitors. Okay, but we'll have to treat the underlying cause to reduce the cardiomyopathy. Okay, so to reduce the long-term risk of cardiomyopathy, we will have to treat the underlying cause. If that is not resolved, then how will you resolve the cardiomyopathy, right? So that is why BP control is also very, very important to reduce the pressure on the ventricles. So this is how you treat the preserved ejection fraction. So in both the heart failure, basically what we are trying to do is reduce the systemic vascular resistance. Okay, so please, that is the gold standard that we are doing with respect to heart failure. Okay, then there is something called as decompensated heart failure, meaning there is a acute worsening. Okay, so there is a heart failure, but if the acute worsening is there, so that is when decompensated heart failure is the term. Okay, so that is where we use dobutamine, and dobutamine will increase the contractility of the heart. Contractility of the heart will be increased. Okay, so the force by which the heart pumps, no, so that will be increased by dobutamine. Okay, so, and I told you, right, there is also another classification, that is left heart failure and right heart failure. In left heart failure, the patient will present with air hunger. Okay, so air hunger will be there, and orthopnea and PND will be there, because here, as the blood is not able to pump out all the blood, all the blood is pooling inside the right atrium, and through right atrium, all the blood that is coming from the pulmonary veins from the lungs, all the blood will stay in the lungs itself. Okay, so that will cause pulmonary edema. Okay, which will lead to orthopnea and PND. Okay, so this is the feature with respect to left heart failure. Whereas right heart failure, meaning, so all the blood that is coming from the peripheries to the heart will be start pooling in the peripheries only, because the heart is not able to, right heart is not able to take all the blood, okay, blood back. So that is why JVP will also be elevated, because all the blood is staying in the right atrium and the other parts of systemic venous supply, and peripheral edema can be seen, and ascites is seen in right heart failure. Please do not confuse the left heart symptoms with the right heart failure symptoms. Okay, then the two gradings of dyspnea, basically air hunger, orthopnea, and all these things also will be there with heart failure, right? So dyspnea can be classified as NYHA grading and MRC grading. NYHA grading, so this is what we do for heart. Okay, whereas dyspnea with respect to pulmonary disorders is MRC grading. Okay, NYHA, please go through this 1, 2 and 3, 1, 2, 3 and 4. Here also it is going to be 1, 2, 3, 4, but one extra thing is 0. Okay, with respect to MRC grading. So this is the grading that we do with respect to dyspnea that comes up. Okay, so if a person comes to you to the clinic, he'll tell there is a difficulty in breathing. So this is how we do. We'll ask them, can you be able to walk for a little while? Can you be able to like walk with your friends, or should you take a rest and all? So this is how we'll grade them. Okay, so based on NYHA grading, so then we'll tell them to do echo, ECG and all these things. So this is how you do it. Okay, so management would be, so in heart failure would be ARNI. Okay, so remember ARNI. Okay, the example is Entresto, meaning, so ARBs. Okay, ARB, one of the antihypertensive I've given, ARB is given. Okay, angiotensin receptor blocker is given. So now the neprilysin inhibitor, I told you, right, in heart failure there is something called as ANP that is released from the atria. So what ANP does is it will activate ENAC channel and allow the water and sodium to get thrown out of the body. Water and the sodium will be thrown out of the body through this channel. Okay, but there is degradation of NAP happening. okay, to reduce the degradation of NAP and increase the water and sodium flow out of the body. So there is something called as neprisilin inhibitor. Okay, so neprisilin inhibitor, meaning neprisilin is what is causing the NAP degradation. So if we inhibit neprisilin, we are gonna stimulate ANP more, right? So that will throw the water and the sodium out. So that will reduce the symptoms of heart failure. So this is the mechanism of action behind ARNI. Okay, so please remember the example, that is Entresto. Okay, there is one more drug. Okay, please remember omeprazole. Okay, so this drug is nothing but the same thing, but here not ACE, ARB, it is going to be ACE. Okay, so it is going to be ACE that is involved in this new drug. Okay, omtrilat. Okay, omtrilat. Okay, so this is the drug. Okay, please avoid cardioprotective drug, that is beta blockers, in decompensated heart failure. Decompensated heart failure, I told you, right? The acute worsening of heart failure. The reason why we are avoiding beta blocker is, if we block, so see, basically dobutamine is trying to contract, and also if we beta action of the sympathetic chain is basically, it increases the heart rate. Okay, but if we are trying to block it, suddenly the sympathetic activation fails and our heart suddenly stops itself, right? So that is why we'll have to avoid beta blockers with respect to, I am giving all the antihypertensives, but we have to stop giving beta blockers with respect to decompensated heart failure. Please remember this point. Okay, there might be a question from this, and you think, oh, okay, anyway, beta blocker is in the option, so let me go for beta blocker for antihypertensive. So please avoid beta blockers. Okay, there might be an exception with this. Then coming to digoxin toxicity, I told you, right? So digoxin is one of the anti-arrhythmic drugs that can be used if there is a toxicity with respect to digoxin. So there the major trigger of digoxin toxicity is hypokalemia, hypercalcemia, and erythromycin. Okay, erythromycin is one of the drug which should be avoided with digoxin. Okay, so remember this. So if digoxin toxicity is there, we are going to use lidocaine, and there is something known as digibind. Okay, so this is the drug of choice, digibind, which is also called as digoxin immunofab. Okay, so digoxin immunofab. Okay, so this is the drug that we are going to give even digoxin toxicity. Okay, this is all and everything you need to know with respect to heart failure. That's it with respect to cardiology. Everything with the cardiology is done. Now we'll move on to the other chapter of thorax, that is pulmonology. Okay, so now the cardiology is done. Now we'll go for pulmonology. Okay, thank you.